Many articles on myalgic encephalomyelitis claim that there are no tests available which can be used to help confirm the diagnosis. Many articles also claim that despite extensive testing, no objective or measurable abnormalities have ever been found in any patients with ME, that all tests on ME patients have always come back normal. These claims are very, very common, but are all completely false. Objective evidence of a whole variety of measurable organic abnormalities in ME patients has actually been available since the 1950s. There are now hundreds of medical studies which have shown a variety of measurable and in some cases extremely severe abnormalities in many different bodily systems of ME patients. While there is as yet no single test that can diagnose ME, a series of objective tests are available today which together can be used to confirm suspected ME diagnosis with confidence. Tests will only all be normal in ME patients, as with all illnesses, if completely the wrong tests are done or if those tested do not have ME in the first place. Many articles also incorrectly claim that it is fatigue or tiredness that is the one essential characteristic of ME. This is also false. Fatigue is not the primary or defining symptom of ME. It is not even an essential symptom of ME. The defining characteristic of ME is not tiredness, but central nervous system dysfunction. In other words, damage to the brain. ME is a neurological disease. ME expert Dr. Byron Hyde explains that the one essential characteristic of ME is acquired central nervous system dysfunction, not chronic fatigue. He says that a patient with ME is a patient whose primary disease is central nervous system change and that this is measurable. Today there are excellent tools available for measuring these changes to the brain. This includes SPECT and PET scans of the brain and neuropsychological testing. That is why it is these tests which are the most important to look at in the diagnosis of ME, although various other types of tests are also very useful. Some of the series of tests which can in combination help to confirm a ME diagnosis include the following. SPECT scans of the brain. SPECT scans have demonstrated decreased blood flow to the brain in ME. This is found most frequently in the frontal, parietal, temporal, occipital and brainstem areas of the brain. These abnormalities have also been shown to correlate with clinical status, which means that the more severely affected sufferers show more severe abnormalities in their brain scans. Dr. Byron Hyde comments that, "I do not describe a patient as having ME unless there is an abnormal SPECT scan." MRI scans of the brain. Areas of high signal intensity consistent with edema or demyelination have been identified by MRI in the vast majority of ME patients, more than 80%. The lesions that have been found in ME are similar to those seen in multiple sclerosis. As with SPECT scans, ME patients with abnormalities on MRI have been reported as being more severely impaired than those without such abnormalities. PET scans of the brain. PET scans have shown decreased metabolism of glucose in the brain. They have also shown decreased blood flow in the brain, particularly in the brainstem. This is the area of the brain most damaged in ME. Neuropsychological testing. Of all the neurological problems that make up ME, cognitive problems are often some of the most disabling. Neuropsychological testing can be used to identify cognitive dysfunction or to confirm a ME diagnosis, as the impairment pattern is unique to ME sufferers and is not seen in other diseases or injuries. The pattern of impairment is one of focal and lateral deficits consistent with a multifocal organic brain syndrome. This type of testing should focus on the abnormalities known to differentiate ME from other causes of organic brain dysfunctions. EEG brain maps and QEEG brain maps. 95% of ME patients or more have been found to have abnormal EEG brain maps. Dr. Byron Hyde comments that QEEG brain maps are even more accurate and that they have also been able to demonstrate not only a lack of normal activity in ME patients, but migration of the normal activity centres from injured areas to different parts of the brain. Neurological examination and the Romberg or tandem Romberg test. Most ME patients have abnormal neurological examination. The Romberg test is a useful test of brainstem function. More than 90% of ME patients have an abnormal Romberg test versus 0% of controls. Tests of the immune system. The immune system abnormalities seen in ME patients are consistent with a viral infection. Specific findings include increased numbers of activated cytotoxic T cells, low natural killer cell numbers, percentage and function, elevated immune complexes, atypical lymphocyte count, significantly reduced CD8 suppressor cell population and increased activation marker on CD8 cells, abnormal CD4 to CD8 ratio, elevations of circulating cytokines and immunoglobulin deficiencies. R-nasal dysfunction of the 2,5-A R-nasal antiviral pathway in lymphocytes. It should be noted, however, that the R-nasal abnormality is not specific to ME. ME is just one of a number of diseases which shares this abnormality. Erythrocyte sedimentation rate. An unusually low ESR of less than 5 mm an hour is common in ME. ME is also one of a very small number of diseases where ESR rates as low as 0 are often seen. Insulin levels and glucose tolerance tests. Derangement of insulin response is a frequent finding in ME patients. Glucose tolerance curves are often abnormal. 24-hour Holter monitor. A 24-hour Holter monitor is a type of heart monitor. This test may show repetitively oscillating T-wave inversions and a flat T-wave. Holter monitors may also show heart rates as high as or higher than 150 beats per minute in ME, as an immediate or delayed response to the patient maintaining an upright posture or at rest. Heart rates as low as 40 beats per minute may also be observed, usually during sleep. Tilt table examination. Orthostatic intolerance is extremely common in ME patients and may manifest as one of or all of the following: neurally mediated hypertension, postural orthostatic tachycardia syndrome, or delayed postural hypertension. A tilt table test may be useful in diagnosing these conditions. Exercise testing and chemical stress tests. Exercise testing is widely used for the diagnosis and functional assessment of a variety of cardiac and metabolic disorders, and this includes ME. Heart rate and blood pressure responses during the exercise test may reveal abnormalities specific to ME, including lower cardiovascular and oxygen uptake values at peak exercise, elevated resting heart rate, and an inability to reach maximum age-predicted heart rates. But exercise tests are not appropriate for many ME sufferers. Dr. Hyde explains that patients with ME frequently cannot do exercise tests, so I then do chemical testing as a second best. There are also a variety of abnormalities visible on physical exam in ME patients. These abnormalities are not usual in healthy patients, but they are also found in those with other organic illnesses, and so they are not specific to ME. The post-exertional paralytic muscle weakness or paralysis unique to ME should also be tested for. A diagnosis of ME should never be made without this characteristic being present. Contrary to popular belief, ME is a distinct, recognisable entity that can be diagnosed relatively early in the course of the disease, within just 2 weeks, providing that the physician has some experience with the disease. The new Nightingale definition of ME now makes diagnosis easier than ever before, even for those doctors with no experience of diagnosing ME. ME is not medically unexplained or unexplainable. ME is just a disease which, like lupus, has no single marker and must be diagnosed using a series of tests rather than a single test. A large number of fatiguing conditions may well be made up of vague and mild everyday type symptoms, have no physical signs and no tests which have shown abnormalities or that can aid diagnosis. But myalgic encephalomyelitis shares none of these characteristics. The neurological illness known since 1956 as ME and each of the definitions of CFS are very different and describe very different patient groups. Myalgic encephalomyelitis is a distinct, organic, testable neurological disorder which can occur in both epidemic and sporadic forms. It is a disease that has been recognised as a distinct organic neurological condition by the World Health Organization since 1969.